and the next one is scheduled for March 25th. And the subject, of course, will be macular degeneration, but the specifics haven't been determined yet. So mark your calendars for the 25th of March. I also want to tell you a little bit about our Centers of Excellence program. We created a AMD Center of Excellence programs where we develop standards that have been identified of utmost importance in the best possible care for the AMD patient. The MDA quarterly newsletter and the Centers of Excellence database are located on our website and is a vital resource for patients to determine certified eye care professionals. To set your practice apart, please visit our website, which is macularhope.org, and you'll see that the Centers of Excellence program is featured there where you can sign up for it and learn more about it. So without further ado, I would like to present our speaker, one of our medical directors, Jeffrey Gerson. And Jeffrey, you want to introduce our esteemed speaker tonight.
All right, great, Larry. Thank you very much. As Larry said, my name is Jeff Gerson, and I'm the Optometric Medical Director for Macular Degeneration Association. And again, I want to echo what Larry said in thanking you for attending tonight's meeting, Low Vision and Primary Care Practice, and echo his sentiment on our March 25th program that'll be given by Leo Sims. So hopefully you'll all look forward to that. But tonight we get to hear a really interesting talk given by Dr. Kendall Krug. I've been lucky enough to know Kendall basically since finishing school, since I came to Kansas, as we both practice in Kansas, and in part because of our mutual involvement in low vision. And really, Kendall was kind of a mentor to me when I first started practicing and helping me to get started with being able to do low vision in my private practice at the time. Kendall is a diplomat of the American Board of Optometry. He was the Kansas Optometric Association OD of the Year in 2018. He has received numerous awards due to his work in low vision. Kendall provides low vision services in his private practice, as well as for the Kansas State School for the Blind, where he and I still get to collaborate. Finally, Dr. Krug is one of Macular Degeneration Association's AMD Centers of Excellence, like Larry just mentioned, because of his commitment not only to low vision, but to holding himself to the highest standards for care of his AMD patients. On top of it all, I can tell you that Kendall is just an all-around nice guy, and I'm looking forward to his take on low vision in primary care practice. So Kendall, I'm really happy and honored to have you with us and look forward to what you have to say.
Okay, good evening. Can you hear me?
Yes, sir. We're all loud and clear. We do still see the presentation mode instead of slideshow on your presentation.
Okay, very good. You would think I would be better at this after this particular year. So is that doing the same thing?
That looks great now. Thank you.
Looks great. All right. Very good, Stuart. Thank you very much. And Jeff, thanks for the introduction. And also thank you for the invitation, you and the Macular Degeneration Association, to present to this group. A topic that I really enjoy talking about. I've been talking about low vision in private practice. I did the first lecture at the AOA conference many years ago, and was really surprised at how well received it was. But you know, like most of you, I have an interest in low vision, but I also have a a private practice, I learned long ago that probably unless you're in a clinic setting or a hospital-based clinic setting that does nothing but low vision, it's definitely hard to pay the employees and myself by doing simple low vision. And part of that story is I've been involved with Medicare coverage issues going back to 2000, getting some of the first Medicare coverage policies in the country for low vision services. And, now we live in a world of evaluation and management codes, and I'll get to that at the very end. But, I'm going to start the presentation with a survey I came across from an eye care journal. And it was about why should you provide low vision services in your practice? It's certainly more convenient. Look where we're at right now with the pandemic. If your patients can get to your office, can we maybe provide everything they need versus referring them out to another place? What I'm going to talk to you about tonight are the fact that there's some very simple things that I don't think we were taught in optometry school about dealing with low vision patients. And that's going to be the bulk of the talk. Simple things you can do with the equipment you already have in your office. And then the third point is, there are other professions that have kind of picked up where optometry has left off. And I came out of school in '85. I thought optometry was the leader in low vision. And I think we've lost some of that. Occupational therapy is picking up where we're unwilling to go. So some thought there. This is just a map showing prevalence rates of vision impairment and blindness for people over the age of 40. Big deal for those of us in the central part of the country, but states with elderly population are certainly going to see more exposure. And it's closing in on 4% of the population over 40 has some level of visual impairment. So here's a survey that was in Eye Care Business. 60 patients were interviewed in a low vision practice, and patients had all seen more than 3 providers before coming to this practice, and were basically said, there wasn't any more that could be done. So they asked these patients a few questions. And the first one is, what was the most beneficial service? Well, answering questions. That's what we do all day. So we talk a lot. And I saw patients today, so I'm hoping I can hold up for another 2 hours, but that's what we do. And I think we, as optometry, we do it better than pretty much any other profession. We're answering questions about coronavirus every day. So we do that well. We listen to our patients. It's part of our training to be able to understand what somebody sees by how they describe it to us. I think we're very good at that. And we generally have time to do it. We're answering questions that should have been asked to the retina specialist. What device did the patient find most helpful? Well, magnifier is a great generic term, but certainly there were devices that they found helpful. Magnifiers, glasses, closer to TV. So those are some things to think about having them available that a patient can at least become aware of. And then what's the most exciting thing you can do since you had your low vision work? Well, read. So, when we take our case history, reading is usually number one on the list of what people want to be able to do. So again, tonight, I'm going to talk to you about some ways that we can help people read. If there's a key word tonight, it's how can we make these people read better? And finally, what kind of training worked best? So back to my original discussion, if we can do it all in the office, it saves the patient time and frustration. They're going to be elderly, they're going to be visually impaired, they may not have the ability to travel. If we can do it all in-house, that's a great place. So of the 3 places I've practiced in a hospital low vision clinic, in a standalone low vision clinic, and now in my own office, I think I do my best work in my own office because I control pretty much everything that gets done. I know the equipment, everything's where it's supposed to be. So that's where I feel most comfortable. Yeah, if you're just new to this, we already know a referral network. Certainly, the retina specialist in your area, you would know your general ophthalmologist. And I'm always happy to receive referrals from my optometric colleagues. Now that took 20 years to develop, but you know, you just got to get your word out. You get a couple of successful telescope cases or something like that that go back to the retina specialist, and their technician writes down that they're seeing twice as good. That gets their attention. They'll start sending you more patients. Services for the blind. Every state has one. Get your name out to the local VOC rehab counselors that you do see vision patients. Veterans Administration, in some parts of the country where I'm at, the closest VA hospital is 3 hours away, but we do have a community-based clinics but they don't provide services. But that's a great place to refer patients into. And as Jeff mentioned, we both work at the State School for the Blind, and I think of the most rewarding work that I do these days, it's working with the visually impaired kids and being able to start their life with on the right foot. So very good. Let's talk about some basics of providing a low vision evaluation. Well, probably the most important part is the chart that we're going to use. And we hope that we're all using the Logmar charts. You're familiar with what those look like. 5 letters per line. The spacing is proportional to the letter size, so it's kind of the V-shaped thing. This was actually developed in Australia, also known as the Early Treatment Diabetic Retinopathy Study, the Belli-Levy chart. But it's basically the chart that's used for all eye research in the United States. Very repeatable. So, of course, we've all seen that. Here in Kansas, it was our legislation changed recently that this is now the standard chart for the school nurses to do visual screenings, because it is so versatile and it's easy to get a hold of. So, you know, we got to talk numbers. And so, you know, this isn't going to be a big number or formula based thing, but the Logmar chart is still based on 1 minute of arc resolution, but that happens at the Logmar 0. Which if you look at the chart where the red arrows are, that's the Logmar 0. And at 4 meters, that would be considered 20/20. And I'll get into some easy ways to convert that after a bit. It comes in various different types. So you can optotypes, the Landolt-C, numbers, letters. You can get letter charts. There's 3 or 4 different sets of letter charts, so you can change the letters for each eye. And then the Leah chart symbols. Now, here's the scary part. This was taught to me by an ophthalmologist, and here we are thinking we know everything about measuring an eye chart. But using, no matter what chart you're using, if we're using ETDRS, you have to understand that the chart is specific for 1 meter, 2 meter, or 4 meter. And then I'll show you how you convert that. There's a lot of numbers on that chart, but it gets very confusing very fast. But what you want to do is look down in that bottom left corner in that little box, and it's going to say, well, this chart was designed for 1, 2, or 4 meters. Now, the rest of it, you can kind of forget. So, you know, maybe don't worry about how do I convert that to Snellen, because there's really a real easy way to do that. So let's take that 40 meter size letter. Let's say we tested that patient at 4 meters. So we would record the acuity as 4/40. But if you take that fraction times 5/5, which is 1, it easily converts to Snellen 2200. And it's the same decimal size. Let's go down a line to the 32M line. So let's say we test that patient at 4 meters. Their acuity would be 4/32. That's the decimal size, but to convert that, you'd take the numerator and denominator times 5, so that converts into 20/160. So without worrying about this Snellen metric conversion, the numbers work out that you can easily do it in your head. And then simply, if I move it to 2 meters, using that same 40 meter letter size, we've now got 2/40, but you then take the numerator and denominator times 10, so you'd have 20/400 or 10/200. So easy way to convert that. And here's the 32 letter. But you know, the beauty of the ETDRS chart is the patient has more letters to see. And so right off the bat, they're not trying to struggle to see that chart 10 feet away. And I think that was always a way to, you know, give them some hope. So just more examples here. Let's take the 6M line. At 1 meter, that would be 1/6. And you can convert that, you take it by 20/20 or 20/120. At 2 meters, it would be 2/6 or 20/60. And at 4 meters, just like that. So now the beauty of working at 1 meter is when you refract them, because since we're at 1 meter, we're going to be over plus by 1 diopter. So it's easy to make that adjustment. When you have the patient refracting at 1 meter, I mean, they have many more choices of letters to look at. Their J and Ds are going to be a little bit easier. So I've found that very simple. The chart is close. It's local form. The chart is close for me, so I can actually touch it and point to the lines. And as I'm getting into my 60s and having trouble seeing and not wearing glasses because they fog up, you know, that's nice to have it close. There is a recording chart. This is maybe more for research where you actually count how many letters they get on each row, and then you use a chart to convert that into a number like 20/962. So if you ever wondered where those really weird numbers came from, they're using the chart where they're actually counting every single number. So you're going to have an office setup, something like this. I've got enough room in my exam room that I can position the low vision chart at 1 meter, 2 meter, or 4 meters. And that works out very well. Then on the back wall of the exam room, I've got my contrast sensitivity chart at 1 meter. So I can do acuity, I can turn the chair around. We've got them reading the contrast sensitivity chart. So, you know, make your life easy. As you see, when we get into the billing section, we got to work fast, but we're still dealing with elderly people and people that may move a little slower. And we certainly want to give them as much time as we can. So make yourself efficient. On to the refraction. That's probably what I look like when Jeff got out of school, I think. But you know, do the refraction at 1 meter. Then you just have to chop 1 diopter off of it. We still like doing trial frame refractions. You got a much bigger area. But there are other things we're looking for. You want to make sure there's not diplopia. You know, how many low vision patients do we see that are referred in and they're 20/20 patients, but they just have diplopia. So those are amazing cases. We have the technology in the office to get some very high quality auto refractions on these patients. And these patients may not have had a quality refraction. And how many times do we have a low vision referral from ophthalmology that, you know, they come in with old glasses, they haven't been changed, told me there's nothing that could be done. And we find out that there's a significant change in their refraction and patient leaves in relatively conventional glasses. So that's always exciting too. You know, if possible, when we see the school for the blind kids, this is another nice way. Because I do most of those exams in my office too. I have cycloplegics if we need it. We've got auto refraction, so we can get some good numbers on them. So get your refraction done first, so you know what the distance refractive error is. Then you're going to bring in the near card. Now the ETDRS near card is basically the same format, and you're going to position it and put the proper add for the distance that they want to work at. I prefer the patient to kind of position it where they're comfortable. I'll measure that and then give the appropriate working add and then measure the acuity. Now, important, that number is going to give you the initial amount of magnification that you're going to present to the patient. It's also going to tell us if we have a big difference between the two eyes. And it's a way to double check your minimum angle of resolution. And I've got a slide on that here in just a moment. But there's a close-up chart. You know, again, same thing, lots of numbers on there. But I just use the left side, the metric number, measure the distance in centimeters, and use the metric number, and the math works out real easy. But that confirmation of acuity is because of the proportional letter size. So let's say we get them 8M at distance at 1 meter. We test their near vision at 25 centimeters, so we're 4 times closer. So 8 divided by 4 would be 2. So you would expect that that patient should get about 2M for the same angle of resolution. Likewise, working with the School for the Blind kids, they may be less familiar with eye testing. I prefer to test them up close first, give them a rough idea, because accommodation is usually not an issue. Get a rough idea of what they can see. So in this case, if they got the 2M letter up close, then we could expect them to see about the 8M letter at distance. So it's a good double check. It's a way to determine if those numbers don't come out right, then you can probably assume that there's some refractive error that's causing it, because the angle of resolution is really telling us what that retina is seeing if it's properly focused. On my adult patients in the office, I'm still going to do a visual field screening, and we like using the Octopus Kinetic 3.4E because of the tie-in with Social Security definition. So if you have that capability, do it. Before I see a patient, my staff has already, we mail the histories out so they don't have to do it, or they can pull it off our website. We're going to have the auto refraction done, their glasses read. They're going to have a kinetic field done before I even go in and look at them in the exam room. So I'm going to at least have a rough idea. Well, this person has a decent visual field, or they've got a real constricted field. So before I really get involved with refraction and crunching numbers, I'm going to at least know how big of an area that they can see, a useful area. So let's look at, what does prescribing for near mean? So we've refracted them in the trial frame. We got their near acuity. Let's say they come in once we put the new refraction in the trial frame. We've got them set at, they're holding the chart at about 25 centimeters. So I'm going to put a 4 add in there, a +4 add for the 25 centimeters. So with that in the trial frame, the patient, let's say they see 2.5M where the top arrow is. The goal is to get them to read at least 1M, because 1M, remember, is standard print 20/50. So the simple formula is you go with what they can see and divide it by what they want. So in this case, they can see 2.5M and they want to read 1M. So we need to magnification factor of 2.5. So in my simple mind, I would just take the 2.5 times that 4 diopter add that they're already using. So a 10 diopter add would seem appropriate for this patient. So I'm going to take the 4 diopter add out of the trial frame, put in a +10. And then the only formula you're going to hear tonight is 40 divided by lens power or distance. So remember, we're the doctor. We're supposed to know where these little lenses focus. So if we take 40 and divide it by 10, that patient should be able to see 1M print at 4 inches or 10 centimeters if you prefer metric. So, that's what I'm thinking about when I see these patients. Get the refraction done, find out what their amount of magnification that they need. Oh, and then by the way, they got 2 eyes. So hopefully by this point, you've determined which eye is better. And that's going to be a lot of the third part of this talk tonight is, what happens if they're not? As optometrists, we pride ourselves in making everybody see binocular. Well, that doesn't happen a lot when you got low vision. And of course, once we get that ad on them and show them how to hold the print, they're not going to want to hold it that close, but, just put it there. We know it should be at 4 inches, put it there so they can see it. And it's pretty darn exciting, even after 30 years of doing this, to get somebody that hasn't been able to read with their conventional glasses for 2 or 3 years to be able to put something in within the first 10 minutes, 15 minutes of seeing them, and they can now read print. So it may be a low add that you can do in a bifocal, or it may be something stronger. So this is my dad. He had macular degeneration, and I learned a lot from my dad. I learned a lot of things that don't work. Of course, he had all the best magnifiers and telescopes and stuff like that. When he passed away, I had a whole box of low vision aids, and I knew which ones were his favorites. But sometimes it works out with a high-powered lens. That nose comes in handy for us Germans with big nose. for him, it worked out pretty darn close if he got it to the nose distance. Now, people are not going to like that, but one of the things about doing low vision in private practice is these are patients that we have long-term relationships with. So we may get them early and they may need a 4-ad 1 year. They may need a 6-ad. We may have to move up to a microscope, but it's a lot easier to move in slowly than the very first time that we see them. The other thing I would suggest you do is, this is just a regular patient, not a low vision patient, but don't worry so much about where that chart for close up is calibrated for. Give the chart to them instead of presenting it at the 40 centimeter distance, say, which is on the left, say, where would you typically hold this to read? Well, she was actually holding it much closer, and her main complaint was reading. So measure that distance in inches, 40 inches, and divided it by the working distance she's actually at, and that's going to give you the ad power. So make it simple. And if you're lucky enough that they have pretty even vision in both eyes, you hit the home run with some flat top bifocals with a 5-ad, and they're reading again. So lenses are available, bifocals you can get a 22 round up to 20 diopters, and the flat top 28's great as well. Trifocals are going to go up to about 6, and progressives. I mean, this is a huge thing. A lot of our patients wear progressives, and then as they go into macular degeneration, they still want to wear them. But how many of you have prescribed a 4-ad? I mean, that's amazing when you can do that, because it's variable focus, and it's not like their world just drops off when they cross that line. But remember, if you're doing a progressive, a binocular case, when your optician takes the monocular PD, get the distance one, but then do the near one, turn the dial to 25 centimeters, and then when you would write up that prescription, you'd have the monocular distance PD right, left, and then you'd have the monocular near PD right and left, which would be the different PD number. So make sure you put that in. I'll usually circle it so the lab sees it, because it's going to be a non-standard lens. Unfortunately, the Univision lens is not available anymore, and this was one of my favorites. So once you got past about a 6, you could just take their glasses and stick on one of these microscopes, and they could be removed. Once you get to over 6, you're not going to be binocular. So if any of you have connections, the Univision, this is actually made by a contact lens company, and I used them a lot, and I thought they were great lenses. I still have a few left over. If you're lucky enough that the patient is binocular, you have to deal with the closer working distance, so their eyes are going to converge more. And this is the formula I use. You take the ad power times 1.5. So in this case, let's say it's a 6-ad times 1.5, 9 millimeters. So you're going to split that between the two eyes. So if you would record the distance PD, and then the near PD would be distance minus 9. And if you want to break it out monocularly, that's fine. It'd be about 4.5 per eye. But that's going to get the center of the segment right along the converged line of sight. Now, here's an idea that I don't know if it just came to me, but this was after maybe 10 years of doing low vision. And I'm going, well, if you got macular degeneration in each eye, and we're trying to get these people to use both eyes, there's this phenomenon, I call it binocular interference, where it's a lot easier to look around one blind spot than 2. So I'm going to talk a lot about occlusion, and why in a case for seeing small detail for reading, in this case, that left eye has a smaller scotoma, and it's much easier to teach the person to eccentrically fixate with one eye rather than 2, because the scotomas will be in different places. But I hope that makes sense. And these people have been binocular most of their lives, and there's some other strange things that happen when their dominant eye, their long-time dominant eye, all of a sudden becomes the worst seeing eye from macular degeneration. And those are some tough cases, and I'll show you some ways around that. But simple ways you can show that to patients is just have them just put on a clip-on occluder. I like using Banggood filters as a temporary way to use that. Or you can just simply put a, if you want to try it for the weekend, they've already got flat top bifocals, just put a little surgical tape over one of the segments that you don't want them to use. You can test this in the office with just a newspaper. If you have a case where one eye seems significantly better than the other, but yet they're not reading well, just give them a newspaper, cover up an eye, cover the other one, and see if their reading speed increases. Yeah, we're just having them use one eye, but we're having them use the better eye. And I don't think this is where I got the idea, but even Farside knew about monocular occlusion, apparently. So, all right, we'll talk a little bit about contrast and illumination, because that's extremely important, and it's something that usually gets overlooked at most of the specialist offices. But I like using the Pelley-Robson chart, and basically, without getting into a lot of math, it's darker at the top and it gets lighter at the bottom. The picture on the left is the standard appearance, and you should be able to see about 2 rows from the bottom, which is 1.8 log units. The picture on the right has been Photoshop doctored to kind of show you what a person with about a 50% loss of contrast would see. So they can only get maybe the top 3 rows. And, I use that 50% number a lot. And I would consider 50%, not adequate for driving, certainly not driving at night. And so there's some reasons to do this. But the main thing is to show them that, well, the magnification by itself may not be enough. Now, if this person had really good contrast, then we don't have to worry quite as much about light. Precision Vision makes a nice chart, and I use this one on my regular patients. It's basically 100% contrast line and then a 10% contrast line. But this is how I make my decision on when we do cataract surgery, when they can no longer read like the 20/60 low contrast line. But it's a good way to demonstrate to patients that, wow, if I don't have enough light on things, it just goes away. So, and a good segue into, why would you use a lighted stand magnifier? Or why do you need more illumination when you read? Very good. All right, so that's kind of the basic run through of what I'm thinking about when I do a low vision exam. But as we do this, as we take the history, I like doing the acuity myself, because you can learn so much from how they read that eye chart. They may read the letters and miss the first 2 on the left, or they may miss the first 2 on the right. That tells me that there's some kind of scotoma in there. So I think the things that they didn't really teach us at optometry school is what I'm going to talk about next. Is you can't kill everything with magnification, and knowing where the scotomas are and teaching the patient how to eccentrically view is, in my opinion, very, very important. And you can't really make sense of low vision. Why? And a lot of our colleagues say, well, I like referring the patients to you because I just don't like doing it. And I have to remake all my glasses that I've ever tried. And usually it's cases where there's a scotoma and they just don't understand where it is, and they're trying to treat them like regular patients. But definition of scotomas, there's just an area in the vision that doesn't function well. And, it's always depicted as a big dark spot, but it's more like a hazy area. And then we have this thing called the completion phenomenon, where the brain kind of fills in that missing information and actually puts stuff that's not there. So we want to know the scotoma, where it is, how big it is, how the 2 eyes compare. And there are ICD-10 codes for these. So, utilize those when you're coding these exams, or I use those if I'm coding for OCTs as well. But to my point, magnification doesn't do anything for the scotoma. All the magnification is doing is it's making the print bigger than the scotoma so you can see it. But the scotoma doesn't go away. And if you have 2 scotomas, one in the right eye and left eye, then the patient says, well, I can see some of the letters are jumping around. And they can't control where their eye's looking. So knowing the scotoma size, where it's at is important, but then how the patient controls that scotoma is the next topic, and that's fixation. Some of the groundbreaking research on this was done pretty close to home for Jeff and I in Kansas City by a ophthalmologist in Kansas City and a vision researcher. And this was back in my early days, but they used a device called a scanning laser ophthalmoscope, which gave a live image of the retina. And they wrote a lot of stuff in the 90s about fixation patterns and scotomas and things like that. So they wrote this paper in 92. Fixation is the act of directing the eye towards the visual object of regard so that that image falls in the center of the fovea. Okay, so that's normal fixation. Eccentric fixation is then when you're not using the fovea, you're using an off the center point to do that. So why is that so important? Well, here's the training part. So there's a couple of studies that showed this. This first one was from a group out of Sweden, Nielsen. And so they had a group of patients, 76-year-olds, average acuity average 2250, and they prescribed microscopes for reading whatever power they needed. But here's the interesting part. That 50% of them received training on how to look off center or eccentric viewing. In the trained group, they could read 75 words per minute after about 4 hours of training. In the untrained group, it's almost 4 times slower. So those are the people that got the magnifier and they were never really taught how to use it. So the training is just as important as the device. So, you know, how do we go about training that, and how can we do that in the office? And when I got started in low vision, I was just fascinated by this. I was able to work in a clinic that had a scanning laser ophthalmoscope, and I thought the technology was fascinating, but the devices were prohibitively expensive. And if you had one of these, Rodenstock made them, you pretty much had to have a full-time technician to keep it operating. And I know the clinic in Wichita actually had 2 of them, so they could always have one of them running. But that's where most of this research showed how fixation works. So let's talk about that a little bit. So this is just a diagram of, you know, when you look at a target, it's going to fall on the fovea, that's central fixation. And let's throw in a scar at the macula like that. So that scar is going to project out into space. So that object that was falling in the macula is no longer seen. Okay. But what eccentric viewing is the eye can learn to look off center. So in this case, let's say this is the person's right eye. We're looking down on top of the right eye. The star is still out there, but the person's learned to turn their eye temporally or to the right. And now that image falls temporal to the macula a little bit. So that's their eccentric viewing position, or what's called the preferred retinal locus, PRL. You'll see that term quite a bit, but that's what that stands for. So that would be right eccentric fixation on a person's right eye. And whoops, I didn't advance my slides. So that shows you what happens there. So they intentionally or reflexively have learned, well, you know, if I turn my eye a little bit to the right, I've got an area there that still works. And that part of the retina, that preferred retinal location, is going to get registered in your brain that, oh, if we train that, I'm going to go to it every single time. So more definitions from Fletcher and Schuchard. The preferred retinal locus, PRL, is the non-foveal point that the retina is using to look at an object. Some people call it the pseudofovea. It's always going to be located on the border of the scotoma, as close to the original fovea as possible. But there may be more than one per eye, and these are the people that their eyes tend to jump around. And interesting enough, they do tend to develop naturally. People don't know they're doing it. Now, occasionally, people will say, you know, when you come in and see the history, look at their eyes, and they may be looking at you or talking to you, but they may kind of be looking at the right side of your face, or to the left or up or down. So look at every little thing that you can to see if you can figure out if they're eccentrically viewing. Another thing they'll say is, I can see better if I close an eye. So that's important to know. It's tough to predict it, but the studies that Fletcher and Schuchard did actually showed that there is a pattern to it. Again, the PRL is going to develop very close to as close to the fovea as possible. And it can be jumping around or it can be steady, just depending on how long they have it. Now this is interesting point. From that same study, they looked at 825 patients who already had macular degeneration. Almost 90% of them had some type of central or paracentral scotoma. 84% of those people, when they took the SLO images, had already developed a PRL and didn't know it. So they're coming into your office and they're already looking off center. So be prepared for that. It's very rare that you're going to see somebody that hasn't learned to look off center. And it's going to probably be the most natural one, or the one that's going to work the best. So again, right eye, left eye, look at those fixation patterns. Is one eye better? Are there ways of detecting scotomas in our office? Well, that's what this section's about. We were all talk about Amsler grid. You can do a tangent screen for close up. You can do something called a clock dial. Or how about, we all have OCTs in our offices now. We don't have scanning laser ophthalmoscopes yet, but the OCT does a pretty darn good job because it has a live image. And I'll show you some pictures of how I use the OCT for determining eccentric viewing. So, we've all been taught the Amsler grid. The studies show that it's pretty darn poor. It's going to miss over 50% of the early scotomas because of this completion phenomena. The brain sees that pattern and it learns that, well, those are straight lines. So if there's information missing, and studies have shown this, that the brain kind of fills it in. I think it took about 50 low vision patients of mine, the first 50 low vision patients that I saw before I figured out what was happening here. So here's the Amsler grid. We were taught in school that, well, if the patient has 2200 acuity and they've got macular degeneration, you tell them, look at the center, they're not going to see the dot. Well, after 50 of these cases that the patient saw something like this and they're 2200, and I said, what do you see at the center? Don't tell them, look at the dot. Say, what do you see at the center? And they say, there's a dot. And I go, well, how can you do that? They said, well, the distorted area is up here. So that should immediately tell you that they've got 2200 acuity. They shouldn't be able to see the dot. They've already learned to look off center. That grid would show somebody that's looking up and to the left. And so the scotoma is going to go wherever the macula is. So that's a great one there because they've already learned to look off center. So I hope that makes sense. It took me a while to figure that one out. Because of the way we were taught at school. Again, their study, they were pretty high on scanning laser ophthalmoscopes, but if you're really meticulous with your Amsler grid and ask patients the right questions, I think the Amsler grid is still helpful. You've got the trial frame on with their near correction, you have the lighting just right. And there have been other methods of where you put polarizers on and try to reduce how much light and illumination, and maybe the scotomas will show up first. But this study they did, that the Amsler grid does miss a lot. So maybe it's not the greatest thing that you can use, but it's a starting point. The nodal vision device would obviously be a great thing to consider for application like this. So I got to thinking, and I had Precision Vision in Chicago make this card for me. And I call a vision disability screening card. But on my Amsler grid, I put a 2050 or a 1M size letter at the center. And I'm going to have the patient, cover up one eye, tell them, look at the center. Most of the time they say there's a dot. So if they say there's a dot, then you know that they've been to another eye doctor probably. But I'll say, no, it's not a dot. And then they start looking a little closer and they start working their way around, up, down, right, left, or you direct them to say, well, what happens if you look up a line or two? They say, oh, there's an A there. And then on this chart, there's a different letter on the other side. So you can do right and left. And it's also got some standard 1M print for reading speed, and then it's got 1M print that's low contrast. But I use this thing every day, and it has that fixation letter in it. So if you can get somebody to read that fixation letter, that's a pretty good sign that they still have some paracentral function, and it gives you a leg up on, what do we need to do, or how do we go forward. Fletcher developed this near tangent screen, and basically it's just a tangent screen that you put at 57 centimeters, and I'll explain that in a second. But you would do this one eye at a time. I just clip it to the back of my phoropter, have the patient sit in the exam chair, but then you just use a laser pointer, and you're going to go from seeing to non-seeing. So I'm going to bring that laser. I'm going to say, do you see the laser? And they say, yeah. Then I'm just going to bring it in until they say I can't see it anymore. And then I've got the same recording sheet over here, and I'm just going to write seen or unseen. And you can kind of plot out a rough scotoma on somebody at 57 centimeters. Now, there's this rule of 57, magic rule of 57, which at 57, if you do that test at 57, then a 1 centimeter deviation is equivalent to 1 degree. And you can do that for any measurement. So if you did it at a equivalent foot distance of 57 centimeters, whatever that would be, you can actually extrapolate it out to 100 feet away and say, well, that's scotoma when you're driving down the streets the size of a Volkswagen. So it's another way to kind of think of scotomas, and the fact that they're angular and they're going to affect them far away too. So that's a neat test. There's different ways of doing it. Another way of doing it is to the doctor or the presenter stand behind the chart, looking at the patient, looking at the chart, and then shining the laser on it. So I use it in some cases. I used to use it more than I do now, just because I get most of the information from the OCT. Clock dial's another simple way to teach it. Eccentric fixation, just have a clock dial pattern with numbers big enough that the patient can read it. But then you put a letter or a word in the center, and you say, all right, I want you to work your way around the clock dial, one eye at a time. At what position do you see that letter better? And that's easy for the patient to understand. The Learn to Use Your Vision training book has eccentric viewing, where they have letters and words in the center. But again, you're just trying to probe and basically work your way around that clock dial to see if there's a direction that they see better. Now, those obviously are all subjective tests, so we would prefer to maybe use an objective test. And that's where we are going to go next, using OCT technology, which it's an expensive instrument. I'm in primary practice. I've got a big glaucoma practice. I got a big macular degeneration practice. So I've had an OCT in my office since 2002. The newest one has the OCA on it, which is wonderful when the closest retina specialist is 3 hours away. But you can use it for other things. And in this case, we're going to use it for determining where that preferred retinal locus is. So here's a color photo of one of my low vision patients. Obviously dry macular degeneration. You can see some RPE atrophy there in the middle. And I don't recall what the acuity is, but I'm guessing probably about 2200. So the question would be, can you tell me where the fovea is? Can you tell me where their preferred retinal locus is, just looking from the fundus photo? Well, it's difficult. You can kind of make a rough estimate from the optic nerve that the macula is probably going to be straight across, and we know that their acuity is down. But if you just do the simple retina map, what used to be called the MM5, we call it the retina map now. This is on the OptiView machine. It tells you everything you need to know. It has a super threshold blue fixation dot, so the patient can see that. And you're going to say, well, look at that blue dot, and I'll usually cover the other eye that we're not testing. So if you can interpret this, I've drawn in where the patient is. Now that upper left image, when you're actually acquiring the image, is live. So you can actually see their retina bouncing around, and that's how you can tell how stable the fixation point is, or the PRL. Or if there's two of them, they may go from that superior edge down to the inferior edge, and that tells you something. But if you look down at the thickness map where I have marked fovea, how do you know, just remember the anatomy. So the fovea is where the macula is the thinnest, and it shows up on the thickness map. So that fovea has rotated down. That means the patient's looking up. So their preferred retinal locus, or their eccentric fixation pattern, is up. That person's learned to look up, and they're constantly using that same PRL. So this patient has a very good prognosis because they've already learned to look off center, and they've got that scotoma above where they're looking. And here's just a little diagram of this. This one was actually done with an actual scanning laser ophthalmoscope. So in that upper right picture there, you can see a little red crosshair. That's the part of the retina they're using. But my diagram shows what's actually happening. They've rotated their eye up. The PRL's superior. And so if they rotate their eye up, that's called superior eccentric fixation. The PRL is going to be above the scar. Another way you can demonstrate this to the patient is just sit right in front of them and say, look at my face. And they say, well, I can't really see your eyes. And say, well, look up a little bit. Look at my hair. And they say, oh, now I see your eyes. So you've really demonstrated to them what you've just found. And that's pretty darn powerful the first time they see it, because they've been living with the macular degeneration maybe for years, and they didn't really know that they were doing this. So Fletcher and Schuchard had this study on this one too. This is that 97 study, 825 patients. They looked at the location of the PRL. Was there anything that was consistent? Well, if you had to bet, they're either going to look up or right almost 80% of the time. So, you know, if you're not as into this as I am, if you have a low vision patient and they're about 2,200 and you're trying to figure out, you know, up or right, you're going to be, those are pretty good betting odds. And that functionally works better. And I'll show you a couple of diagrams of why that is. There was another study, I think, that was done around the same, actually earlier than the Fletcher study of 97, which showed the same thing, but a smaller study, 24 patients, but they found the most common location was to the right or above. And, you know, in our society, we read from left to right. So having a scotoma above or to the right is easier to learn to read around, kind of like having a right hemianopsia. So how would this look to you on the Amsler grid? Well, if they reported distortion above the star, it'd look like that. That's 39% of the time. Or to the right, this is the right eye, it'd look like that. To the left is next most common, and then down would be the least common. Downs, you know, we don't want to go that direction if we can avoid it. So can you train that? Well, you know, they've looked at that too. And some experts say that you can't. Nielsen said that you can establish it by training. I'm more of the opinion that they've probably already developed it, but they've got two eyes and you can maybe pick the one that's the most advantageous for what they're trying to do. And so, you know, if you can reinforce what they've already naturally adapted to is how I would look at it. So if we take a look at my fundus, that's straight ahead, right eye. You know, superior eccentric fixation would be up there. Temporal would be over here, inferior there, and nasal there. So if you're looking at the fundus when you're doing the OCT, it's always, if we call it nasal eccentric fixation, that means it's on the nasal border of the scotoma. If it's superior, it's going to be on the superior border. So it's really pretty straightforward when you think about it. All right, location of that trained PRL. You know, which way is it better to do? Would looking up be better if they're doing that, or would be looking right or left? Vertical eccentric fixation is perpendicular to the line of sight, so it's going to look something like that. So you got the dead spot in. If we can train them to look up, the scotoma goes up, and you can see the whole line of print. Now, we're not talking about magnification here, but when we determine the level of magnification, it's going to be when they're in the eccentric position. So, you know, if you look up a little bit with normal vision, you do lose best acuity, but that's where the magnifier part comes in. So I really like teaching them eccentric fixation first, and then add the magnifier later, because then you've already trained them how to use their eye. This would be lateral placement. You know, going right or left is a little bit harder because you've always got that dead spot. It's kind of like shooting at a moving target. You got to lead it a little bit. So let's kind of look at the diagrams of, you know, what each one of those would actually look like. And when I first started doing this, I'd have to get my little Merck eye model out and kind of get behind my right eye and say, well, if they're going left, it's going to look like this. So here's the right eye looking for above. Remember, you've got a natural blind spot, nasal, which is going to be temporal to your normal fixation point. So this shows us somebody with a central scotoma in their macula, and then they've got the natural blind spot from their optic nerve. So there are your scotomas, and the natural scotomas from the optic nerve and the macular degeneration. And then what happens if they did nasal eccentric fixation? Well, that's what this picture shows. They're going to turn their eye to the left or nasally, and the image PRL is going to be between the macula and the optic nerve. So that's the OCT image down below. So the crosshair is where the blue fixation light is. So you can see very nicely what that's going to do. Now, is that a very good position for fixation? No, that's the worst one there. Remember, the nasal direction is the least likely to happen, but in this patient, they did it because you're bracketed. You've got the PRL, you can see the star, but then you got a dead spot on each side. So it's very difficult to read rapidly with that. You could spot read letters maybe, or short words, but that's not really going to work very well. How about temporal eccentric fixation? So here's another OCT image. You can see where that person's PRL is. It's on the temporal side. So that's good. So here's the eye diagram there. The blind spot, a scotoma is the red one. The macular degeneration scotoma is the blue one. And because they're turning their eye to the right, they've got a big area that they can use unobstructed. So that's a good place right there, temporal. And then, I'm sorry, I'm looking at the wrong slide. So there's the one we just described. The PRL is on the temporal side of the scotoma and of the macular scar, and the scotomas are to the right. So that one works pretty good. And then here's a superior one. So you see the OCT image. That person is looking up. So they're seeing their PRL, where they're seeing the fixation dot is on the superior border of the scar. And then that's pretty easy to see. Now, superior is best because you have an unobstructed left to right field of view there. So that's the one we usually want to be able to use if we can. And again, that just kind of shows more detail of what a superior eccentric fixation. So remember the one where you saw the picture of the person, you say, look at my eyes, and then you say, look up. That would be that case. So, you know, so if you're doing this, superior is going to be best for reading left to right if you can. If you have to use inferior, it's going to be if the scar extends more into the superior field of the macula. If you have to go sideways, try to go temporal if possible. And remember, in the left eye, that would mean to the left, and then the right eye, that would mean to the right. So here's that picture you saw earlier. You see now why it's important to know which eye we're looking at. And again, if it was a normal binocular functioning person that got the macular degeneration, they were still going to try to use both eyes. And so try to find the eye that has the smallest scotoma, the best fixation pattern, the best acuity. And that's the one you want to work with. Whether it's a handheld magnifier, you teach them, use it with the left eye. Or if you're using some kind of spectacle mounted aid, or if you're fitting them with a telescope, you want to do it with the left eye in this particular case. You know, you're not going to make the right one any worse. So don't worry about it. The Jose and Fletcher book, Jose and Freeman book is what I use for some of my training. It starts with one letter, and then it goes to 2-letter words, 3-letter words, 4-letter words. Basically, you get the size they can see and teach them to look up or down by following the lines. And then you want to, let's say they can see that these words by looking at the first line above. We'll just, you know, have them go through this 5 minutes every day or 10 minutes every day. And if you make the print big enough, they don't even need a magnifier. But basically, you're trying to stabilize the eccentric fixation position. So then when we do give them a magnifier, they can hit the road running and they already know how to do it. And, you know, if they're using a closed circuit TV or if they're watching television, they learn to look in that same position. Tell them to look at the top edge of the TV. You're going to see it better. So everything they do in their life is going to be better with eccentric fixation. The learning to use your vision for reading book, I used that a lot earlier in my career, and it just has this is something for the patient to actually buy. Is made by some educators, but basically learning how to look off center, giving them large words to learn to look off center without a magnifier, and then going to multiple lines and then reduce the size of the print. You can also use the, if you do the near tangent screen, you can actually just take your copy of what you've plotted out the scotoma, put it on your copier and copy it to an acetate sheet. And then that becomes a scale model of the scotoma at 57 centimeters. And then you can kind of use that as a demonstration aid of, you know, well, you got the scotoma there. If you learn to look up, then the scotoma is going to kind of go away. How far off center? And that's where that rule of 57 comes back in. One of the Nielsen studies showed that in this group of patients with about 2,500 vision, the average eccentric viewing position was about 6 degrees. And you can calculate how many centimeters that is based on that formula. But for most people, it's 3 to 8 degrees. So that's about how far off center they're going to have to look if they're, you know, 2,400 to 2,500. You can extrapolate it by using the rule of 57 if you want. So anyway. And finally, the dreaded ring scotoma. So this happens in geographic atrophy a lot. And these patients will say, you know, if I got enough light on it, I can kind of see things. And remember that scarred area still has some photoreceptor function, but it's really good right in the center of the donut. These are the people that will have this paradoxic result on the eye chart. Let's say, you know, if they can see 20/20 in that central area, you know, you would think that if you gave them magnification, they would see better. But in this case, they actually see worse because you're increasing the size of what they're looking at into that scotoma. So it's tough to treat ring scotomas. And you know, how many of our patients end up with geographic atrophy, but you treat it with illumination. So these are the patients that you just got to give them a lot of light and they'll see it somewhat better. So lighting is important in that case. You know, certain conditions that are not going to be safe for driving. So, all right, we're coming to the end of the scotoma part. So, but I did have a few cases that I wanted to share with you on the scotomas, and these are kind of interesting and just kind of shows you what you might run into and what it looks like. So this patient's a 43-year-old young lady I see for driver's license. She's got retinal dystrophy. And she came to me at -150 sphere at CM 2150. She came to me about 10 years ago, and she's pretty darn the same thing. She had been told at the time that she had to have a telescope to drive in Kansas, which is really not the case. But if you're trying to sell somebody telescopes, then I guess you tell them that. But you can actually drive in Kansas, but you have to have a drive test and you have to pass that. So telescope might be helpful. So that's what her OCT image looked like if she looks straight on. The right eye, left eye, they're basically the same. But when I had her look at the fixation point on the OCT, she's at the superior border. And then if you look at the picture below, you can see the fovea is for sure down. So she was looking up and she sees very well. Both eyes basically the same. This is a great case for the Occutech Flip. This is a low magnification telescope, about 2.2x, but it has a very wide field of view. And I use this a lot if people want to drive. I'm a big believer in they need to be able to drive without the telescope before we introduce the telescope. This one's very usable because they can flip it up and down. You can put a carrier lens in there. In this case, with the retinal dystrophy, she did very well with a CPF tent. So that's a great case. This year, her dad came in and guess what? Dad had the same exact problem and he had somehow made it into the Army and they just thought he didn't see well, but he was in the Army and had macular dystrophy and finally went to an eye doctor who apparently could explain it to him. And so he's got one of these now too, and they see roughly the same. More typical macular degeneration patient. This is a 87-year-old retired farmer. He's now widowed, lives at home, and he was still driving. I'd seen him in 2012 and he had relatively good acuity in that right eye, was able to read with a stand magnifier, also was pseudophakic. He had wet degeneration in the left eye. So what happened was when he came in at this point, his acuity had dropped in both eyes kind of equally, but his right eye 2400, left eye 2800. And then a near acuity showed the same thing. So right off the bat, I'm looking at, well, the right eye is going to be our eye that we're going to work with. Contrast sensitivity severely reduced, but again, better in the right eye. So we got 2 tests that show the right eye is better. Kinetic field's really pretty good, pretty full there. The way you interpret that, right eye, left eye. In this case, I was preparing this one for a lecture. So I said, well, let's go ahead and do the macular program on the octopus. And certainly you can see the left scotoma is much denser than the right. Not that that gives you a lot of information. That's what the near tangent looked like on this guy. And that's what his OCT image looks like. So he had some disciform macular degeneration, but look at those the line images. He also was esophoric. You can see that the macula is shifted to the left, and then on the vertical cross section, you can see he's also looking up a little bit. So that's his right eye, and then that was the other eye. So just much more extensive scarring in the macula that made sense. So what do we do with this guy? Well, he's now profound impairment, left eye worse than the right. Right eye had the residual function. He'd already learned to eccentrically fixate. And so he was able to accept the magnification. We just increased that a little bit, but instructed him, you got to use it with the right eye. Keep using superior eccentric fixation. I ordered an occupational therapy time with him. And he was fortunately a veteran. So we were able to get him closed circuit TV, but had to tell him to not drive anymore. We got a lot of farmers out here in Kansas. So here's another one. A lot of veterans, doesn't drive anymore. Pseudophakic both eyes, dry AMD, typical 2100, 2250. So look at all the numbers. So the right eye, slightly better distance, slightly better near than the left. So, I'm thinking right eye might be better. But when I got the new refraction, he was actually about the same in both eyes. So I'll look then, well, what about near? Well, again, the right eye still seemed to be a little bit better than the left. quite a bit. He had quite a bit of diplopia, so we got to add some prism. Contrast was equal between the two eyes. So this is a guy that pretty even vision, even contrast sensitivity. We want to try to give him a binocular correction is the way I looked at it. We could go up to a 6 add in his glasses, and that was helpful. With a lighted hand or stand magnifier, he could do even better, probably because of the contrast issue. That's what his OCT looked like. Again, superior in the right eye. Left eye, probably not as good because he had more scotomas to shoot around there a little bit. So, and that was the assessment on him. And the OCT showed me that he had long-standing esotropia. Again, these are patients that this one was referred to me, so it was the first time I saw him. But if you have that information before you even get started, it's pretty darn helpful going in. Reinforces eccentric fixation position, and some of the things that we've already talked about. If we could make him not see double, that was helpful for his glasses. So, and then I got one more here, I believe. Another veteran. He's diabetic though. Low vision runs the gamut of what we're going to see. We like getting those 2100 patients, but this guy, best he could see was 2460, 2200, 2M up close. Terrible, terrible contrast. He was diabetic. He'd had PRP, and so that's what his visual fields look like. So his problem is more loss of visual field in both eyes. And that's what his OCT in the right one looked like. He's shooting around a lot of scarring, scotomas there. Here's his left eye, and there's the tangent on his left eye. He's just got a small island in there. So, what was my assessment on him? You can't fix everybody. I can at least explain to him why he didn't see, and why some things would happen where vision would pop in and out. But with the severe contrast sensitivity, he's really not a good candidate for conventional low vision aids. It did tell me that his left eye had the best function if we could teach him to inferiorly eccentrically fixate. So what I did in this case was, well, before we give up on him, we'll do some OT, see if we can get that left eye stabilized a little bit better. And then the goal would be to get him to use a closed circuit TV if we could stabilize it. But again, find the eye that has the best. And in low vision, we're just salvaging what we can. So here's just a couple more quick examples. Which eye would you use in this case? Use all the information you have. Right eye, better acuity. Right eye, better contrast sensitivity. And certainly better scotoma, not the greatest, but the left one, he's got a ring scotoma there. And here's another one. Right eye 2200, it looks like he's doing superior eccentric fixation. Left eye's 2400, and he's got that bad nasal PRL there. So easy case there, you'd want to use the right one before we even get started with low vision aids. So summary of for this section would be, it's easy to detect these, but when you can actually see them in real life on an OCT, that's pretty neat. It not only shows you the size of the scar that we're dealing with, but it shows us the direction of the PRL. You might be able to train the PRL with time. We've learned that if we can get them to go up or right, that's the best direction. So try to find the eye that fits that. When you're training them, start with large print with no magnification to look off center, and then reduce the size of the print and add the magnifier. Ring scotomas are difficult, and that's going to be common in geographic atrophy, but the best we can do there is increase illumination and make them understand. All right, here's our first question of the night. So I think somebody's supposed to jump in here.
I think Holly's going to post the poll question for us, Dr. Krug. If I could read out a few of the questions from the audience that's been coming in tonight and have you address some of those, please. Our first is from Dr. Driver, also in Kansas, I believe. Do you have a favorite brand for progressive high ad I can only get a 3.25 max plus 3.25.
Yeah, you can get the Verilux. I don't know if it's the S or the X, but it goes up to a 4. That's typically what we use. You may find that you have to go to some of these specialty labs, Winchester and Chadwick, which are on the East Coast. They can do special tints too, but Essilor does make a 4 ad.
Okay.
And hi, Dr. Driver.
And how much appointment time do you allocate for your standard low vision exam?
That varies. The kids, we go about an hour to an hour and a half. On adults, it's about the same, but I got a lot of the work done. And this depends on if we have to dilate them or not. And we'll talk about that a little bit in the documentation part of this lecture. But, if I have all the stuff done, I could get through it in an hour. But, I only do low vision maybe a half a day a week. And I'm booked out probably 3 to 6 months on low vision patients. But again, I've got a regular practice to run too.
Okay. Do you have any information about eSight devices that work to use peripheral vision to help patients see centrally?
I've not used the eSight. It's a kind of a virtual reality headset type thing. I use the Iris Vision, but these are basically virtual reality goggles that you put on. They have a display. You can put different information in it, and there's even one that does visual field testing. I was involved with the low vision enhancement system that NASA and Johns Hopkins dreamed up back in the 90s. And beware of anything that's not developed by a low vision specialist. Electrical engineers and people like that, they think they can do everything, but they're not dealing with scotomas. And a lot of that stuff is extremely expensive. And yes, I have an Iris Vision in the office, but we very rarely even pull it out to show the patient.
Okay. Next question. Is there a relationship between the locations with the high attentional capabilities in the visual field and the selection of the PRL?
Ooh, wow. That one gave me a headache. So can you read that to me again?
Sure. Give me a second. Let me pull it back up. It says, is there a relationship between the locations with high attentional capabilities in the visual field and the selection of the PRL?
Wow, I'll take a stab at that. My email's at the end of the lecture. You can contact me on that one. But the field that would have the highest usability would be the one you would want to use. I think that's kind of how you phrased it. So the eye that they tend to want to use. Now, you'll run into a problem where you'll have amblyopic patients that all of a sudden their amblyopic eye, their entire life is now the better acuity eye. And those are the cases, and I'm going to talk about that in the next section, where you have to kind of dance around and figure out which one can you get the best vision out of. But you're going to have to actually occlude the eye that they're trying to use. So that might be the more attention eye that they're more wanting to use because they've naturally used it more in an amblyopic patient. But if they lose their high functioning eye and they have to deal with the amblyopic eye, that's a challenge. And I've got a way to, the next section, I hope would explain that to you.
Okay, there's a couple other questions we might just type some answers to afterwards, or a little more specific. I'll let Holly share the polling results with you, and we are at 25 minutes remaining at this point.
Excellent. Well, it looks like you all got that one. 69% got it right. And the second position would be temporally. So you got that, the top two, we got almost over 80% of the respondents. So, all right. All right. This is a topic I love because I don't think I discovered it, but I kind of came across it by accident. So I call this the $8 reading aid. So how many of our patients do you have this complaint? They just drive you crazy. They pull your hair out. So some of these are low vision. I call them functional vision loss, but this has to do with even non-low vision patients. But basically they've got this complaint of reduced vision, particularly they have trouble reading under binocular conditions. So started searching the literature, and the AJO had an article in here about double vision in patients with epiretinal membranes. We see these every day in our practice. And this is looking at 50 patients with epiretinal membranes. And some of them had this retina misregistration thing. Some of them had strabismus. Some of them, the double vision was due to a refractive error. And some of them they didn't really figure out. Well, that's all and good if they have it, but what do you do about it? Well, we see these patients that, they complain that they have trouble reading. And so I think a good thing to have in your exam room is a text chart or just a newspaper, and pull it out and, have them read a little bit with both eyes and then cover an eye. See if there's one eye that's, if they read faster under monocular conditions than binocular. If you've done your exam, you've already got the visual acuity. But a lot of times they're going to have this history that their more dominant eye historically actually now has the worst acuity. A lot of times these people are going to have a history of amblyopia or diplopia. The characteristics are, if you do a reading speed test, the reading speed is going to be down. Their binocular reading speed test is going to be slower than their monocular. They may have unequal contrast sensitivity between the two eyes. And a lot of times they'll even tip you off. They say, I can see better if I close my right eye. So those are always neat. Another reason why you should be involved in that history. So we use an MN read chart to measure reading speed. If you want to get it accurately, you can get this on an iPad. Basically, it's a 13-word sentence. You measure how many seconds it takes to read it, and then it calculates reading speed. But then you also plot that against the letter size. And of course, we want them to get down to 1M print. So you can plot it out if you want to, but to make it easy, you just take 600, divide it by how many seconds it takes to read it. It's going to give you how many words per minute. And most people, as you look at that chart, the bigger letters are easier, but then when you hit their maximum reading speed and the letters get smaller, the reading speed goes down quite a bit. We do the School for the Blind kids. I like using this test because it kind of tells the teacher about what size print they should be using. When I researched this further, there's not a lot out there about eye dominancy. And, the best I could find were some obscure references that probably about 2/3 of the population is right eye dominant, regardless of their dominant hand. There are a few that don't have a dominant eye, and it doesn't always work out that the dominant hand and the dominant eye are the same. So one way you can do this is kind of how we fit monovision contacts. I'll just put best corrected acuity in the phoropter or in a trial frame, and I'll just put a +2 in front of them at distance, and it's gonna, you try it on the right, try it on the left. The eye that it bothers more, or you say, does it bother you more if I put this on the left eye or the right? It's gonna bother more when you blur the dominant eye. So you've kind of got that figured out. That's the way I do it anyway. So what happens if we don't want them to be binocular? I graduated from optometry school. I've got my state license and all that. So, I don't think they can take it away from me. But, I get the opinion that we were taught that everybody has to be binocular. But there are some cases where it does you can function better. I had a kid last week, 10-year-old, reading at a 2nd grade level because he had a right Duane syndrome. And he was trying to read with both eyes. And so he'd go double. You simply put a Bangerter filter on one eye or sector so he wouldn't go double. I mean, that doubled his reading speed. So when we don't want them to be not binocular, you can do defocus. You could use an opaque lens. I've used a contact lens with an opaque pupil a couple of times in my career. You can do opaque IOLs. Who knew? Or this thing called a Bangerter filter. So to get penalization from defocusing, you'd have to over minus them by 3 diopters, and that's what you'd want to use for close up, because if you over plus them, it takes about 6 diopters, but for near, that's actually a magnifier. So you'd want to over minus them. And some people that works. Remember, when you blur it, that's a high frequency reduction. And there's, you can use an opaque lens. So this MENS lens made by Chadwick Optical is a nice, you can see it's got an AR coating on it, but it's just frosted on the back surface. So you can still see light coming through it, but it blurs it enough that, you know, you really can't see up to 2200. Me being the private practice cheapskate, I use 500 grade grit paper. So it's kind of like sandpaper, and you can do a really good job on a scratch resistant lens. You want to do the back surface though, just by sanding that lens. And you can see in the picture here that the top image is the high dollar MENS, and the bottom one is the lens abrasion. So if you're sure that this is going to work, that's a cheap alternative. You can do it on the glasses that they already have. And, you know, we do occasionally run into intractable diplopia patients, have had strokes or something like that. And that's a reasonable thing to do. It's harder to do occluder contact lenses because we really don't have many options in conventional lenses anymore. But there was a lab in Denver that I used to use for those. So along came this idea of, well, what about occlusion with something called a Bangerter filter? And so if any of you do pediatrics, you're familiar with the Bangerter filters. They were basically developed as a treatment for amblyopia. It's basically a film that you put on the lens that blurs the good eye to the point where the amblyopic eye will start working. So it's an alternative to occlusive patching. And it's made in Switzerland, and they come in various densities. So there's been some studies written on this. Here's one of them. The description is just this plastic membrane. So it's kind of like a Fresnel lens. It's got these little bubbles in it, and the more dense the bubbles, the worse the vision is. There's a microscopic view of them there. But the interesting thing about Bangerter filters is they produce blur without really reducing the contrast vision. And maybe that's something different. So we talk about channels, you know, there's a blur channel, there's a contrast channel. Maybe those are different things. So it produces blur that's different than defocus. So these are kind of interesting pictures, these resolution charts. So the first column there, it says Bangerter, that's a 0.8 filter. So that's like a 20/25 blur. And the 0.4 is less than that, about a 20/50 blur. But you see that radial pattern, that's the contrast bands. Compare that to defocus. Defocus tends to blur out the high frequencies more than the low frequencies, where the Bangerters pretty much do the whole band. They blur all frequencies the same amount. And so that may have something to do with this idea of how do you get the eye to suppress. The density of the filter depends on the level of suppression that you need. And this is from that same study. It showed that you got the maximum image degradation at about a 0.4. And even if you went to a 0.3, it didn't do as good as the 0.4. So looking from that study, likely you'd want to use a 0.4 or 0.6 for most patients. Interesting, you can still have some stereo acuity using a Bangerter filter, so it doesn't blur it as much. When you defocus, the amount of blur is proportional to the amount of defocus that you make, whereas the Bangerter filter is more about 1 to 2 diopters. So they made this comment in the study that you know, it may have something to do more with this these frequencies, spatial frequency channels. Monocular defocus caused a loss of stereo acuity disproportionate to the loss of visual acuities in defocus, whereas the Bangerter filter, it was more proportional, the degradation of both stereo acuity and visual acuity. So you can get a Bangerter foil bar from your optical supplier. And it's basically just a Snellen acuity. So a 0.8 filter, approximate acuity is 20/25. A 0.4 would be 20/50. A 0.1 would be 2200. So you kind of pick the level that you want to blur them to. There was another article in the AOA journal back when we had one looking about, can you use Banggood filters for diplopia? And yeah, it can be. And it's certainly a much better, it's a much better looking lens than having a black patch on them. We really don't know what the long-term effects are, but I've had a couple of cases that I'll share with you where, the person didn't have to wear it forever, and their brain kind of recircuited to where we got them to use the other eye. Those are some of the suppliers. They're not expensive. I keep a whole box of them here in the office, and you occasionally get a CVA patient that comes in seeing double, and we can fix them up right away while they're here. Pretty easy to apply. Just make sure you dampen the lens. Use alcohol because it evaporates. The foil has a shiny side and a side with the little bubbles on it. You want the shiny, smooth side to go against the lens, and put it on the back surface of the eyeglass lens. So that's kind of what one looks like there. That's a 0.6. So you can still see through it. And I take the lens out of the glasses and cut it to the shape of the lens, and then put it back in. So got a couple of cases here, kind of interesting. Macular degeneration case, right eye worse than the left. And in her case, her right eye had been her long-standing dominant eye. She told me that. And because, she now has the right eye has worse macular degeneration, and she had trouble reading for pretty rapidly. So here was her case. The best she could see out of her dominant right eye was now 20/50 because of the change, and her near vision was also reduced significantly. But the left eye was very, very good. But yet she could not use the left eye because she was so right eye dominant. Even if you look at the contrast sensitivity, it's also telling you that the left eye was better. But look at the reading speed. Under binocular conditions, she could only read 2M text at 100 words per minute. If I covered her right eye with the same glasses, she was reading 1M twice as fast. So very right eye dominant person, and trying to use both eyes together. And everything seemed to match up pretty well. And these people can almost immediately tell you that it's better. So I think this is that same fundus you may have seen earlier. And that's just showing you the fundus picture and kind of where her PRLs were on the right eye. But here's her left eye, and she was still pretty central in the left eye. So how do you do it? Well, I just put her in the trial frame with the near correction, and then I would introduce the Banggood filter in front of that right eye that we wanted to blur. And then you just slowly increase the density, and it's almost like a light switch. You'll get to the ones, and she said, okay, I'm not double anymore, or the letters are clearer, even though you've not really changed the lens. We've just turned off the right eye. So in this case, that was pretty straightforward, and it's worked for her very well. But remember, her contrast vision was still fairly reduced. And so I got her some of these, Eschenbach sells these. It's actually reading glasses, but you can trade the lens out. So I just made her a reading prescription, and we put the Banggood filter on the right side. And then these are the light specs. So they have LED lights built into them. So for some patients, that's nice to be able to do. Here's that little 10-year-old with Duane syndrome, reading at the 2nd grade level, sees double, turns his head to the right because he's got Duane's. Remember, he can't turn right in that right eye. Straight ahead though, he's 20/20, 20/25, but he gets double vision on right gaze. So there's an actual picture of him. He can go left, both eyes. He's straight ahead, he's okay. But when he tries to go to the right, the right eye can't go out. And look at the acuity. I've seen these before. The eye with the Duane syndrome actually has the better acuity. And so that makes it doubly hard because they want to keep using that one. Contrast was the same on both eyes. So he He did, I'm sorry, there's the picture of the eye, the bottom picture, the right eye cannot abduct, but he's binocular everywhere else. So, that was a case where we just put the filter on the right half of that right lens, so he could still be binocular at some point. And that at least gets him functional for school, so he doesn't get any further behind reading at the second grade level when he's in 5th grade. And, maybe he'll have strabismus surgery, but it certainly gives you that option. Probably one of my most complex patients I've ever had. She was a 55-year-old occupational therapist of all things. She'd been a long time RGP wearer of mine, about a -9 myope, normal vision, never had any problems. 2012, she had a retinal detachment in her right eye. Had it repaired, repair went well, but subsequently developed a cataract in the right eye. And oh, by the way, that was her dominant eye. She was doing monovision, right eye distance. So she had the cataract removed in the right, and then subsequently had a clear lens extraction in the left, so she didn't have a 9 diopter aniso. And, we thought, we got to that point, we got, man, she's lucky. She can see 20/20 now, 20/25 in the right eye, not a big deal. I thought I was home free. She was the most miserable patient I've ever had. She would come in twice a week without an appointment, in tears, seeing 20/25 and 20/20 with her glasses, even with a little spectacle prism correction. But she was right eye dominant and definitely had this dominancy thing. OCT revealed an epiretinal membrane. So she ended up having that causing some of her blurriness in the right eye too. So, this is that retinal rivalry thing. And so even after all those surgeries, we really didn't have a good option. And I was about ready to give up on her. Occlusion helped her. And so this is actually one of the first patients I tried the Banggood filter on. And so we put a 0.8 density. So that's only like a 20/25 reduction on her right eye, and it almost immediately eliminated her symptoms. And that sound, you think, oh, that it doesn't happen that well, but when it's a binocular problem, the relief is almost immediate. So it's not a bad idea to maybe have a Banggood bar in your drawer, because they can be helpful. There's a picture of the glasses, the Banggood filters on the right lens. I mean, you can just barely see it there. And when it's on her, it looks like that. Now, she wore this long term, and at about 9 months, we took it off, and she's done well ever since. But there was a point at the beginning stage that if we took it off, she couldn't handle it, give her a headache, and she was just not a happy person. But it helped. So she tolerated it well. We were able to eventually take it off. So summary on this section is, I consider occlusion maybe a good thing for some of our low vision patients, and Banggooders are a simple way to do that, and they tend to do very well. I mean, it either works or it doesn't, and I think there's more of this out there than we realize. I mean, how many of your patients have epiretinal membranes and they were 20/60 and now they're 20/25, and we think that they're doing really good, but yet if they complain about reading, think about trying a low density Banggood filter on the eye that had surgery. A lot of these people will have that history of an amblyopic eye, which is now their better seeing acuity eye. That's another good place to try to get them to use it. So a quick review of some of the new low vision aids that are out there, some old, some new. Lighted stand magnifiers have been around a long time. LEDs in these are the way you want to go. But the nice thing about the Eschenbach series is, remember what those numbers mean. It gives you a magnification number, it gives you a dioptric number, but that 250 is the distance you hold that lens to your eye in millimeters. So that's a good starting point, when you give the patient this. And then remember, you got to tell them which eye to use it with, and we've already been through that. Occutech makes some pretty amazing telescopic products. If you want one telescope in your practice, I'd get the Occutech Flip, because it can help a lot of people. It's intuitive to use. It's a lot of fun, and it can double their vision. And so, how many 2100 patients do you have that wish they could see 50 that's something this simple to use, and you can still put their carrier prescription in the carrier lens. They just came out with their Falcon, which is their second generation of an autofocus telescope. It's now in 3, 4, and 5x. I've used this on a couple patients, and it's amazing. It's a little bit bigger, more expensive. You have to carry that little battery pack with you, but it zip focuses that fast. So if you have a patient that's a good telescope user, but they want to be able to use it at different distances, maybe think about that. I use a lot of their sports, and they make that small Explorer, which is great for kids. It's quite a bit smaller. So think about those. I've really gone away from designs for vision products. They're just difficult, expensive, and these you can do most of it with your regular lab. Electronic vision aids, I mean, the price comes down on this stuff all the time. Most of the closed circuit TVs you have now will have text to speech built in. So we'll actually read it to you in a voice. If you have students, you can get these USB cameras that plug into their laptop, and they can use it to look at distance objects, or they can rotate it, and it can look down like a closed circuit TV. But yeah, you can save images as a JPEG file, so they can go back and review them later. That's called the transformer. That's the Iris Vision. I've got one of these in the office just because I like head-worn stuff, but it's basically a Samsung cell phone off the shelf with a VR goggle. They put software in it so that it responds to voice commands, so you can tell it to magnification up, magnification down. It's got different modes. It's got like a bioptic mode. You can put print in front of it and read it. And it does have internet access. So it's a platform that they'll be able to continue to change the software and add new features. If you have a functionally blind person, Orcam's out there. So this is not a visual aid. It's a small camera with a environmental detection device that basically whatever this thing sees, it tells them in a voice what it is. So it needs some training. So it's kind of like tagging somebody on Facebook. The next time this thing sees Bob, and you've told it who Bob is, it'll say Bob is in the room. You can read it will read to you just by holding printout in front. And it's not that expensive. It's $3,000, made in Israel. So a neat thing, and it's been out there for quite a while. If you get nothing else out of this lecture, write this one down. This is an app for your smartphones, iPads, iPhone, or Android devices. It's called Seeing AI. It's free. Microsoft makes it. It does lots of neat stuff, but it's a magnifier that uses the camera on the phone and the display, but it will recognize people and tell you who it is. You can put it in front of text, and it just starts reading it to you in a voice. It will read barcodes at the store. It will describe scenes that it sees. So it does some amazing things, and it's free. And if you can have that in your exam room, especially, I've got a lot of 80-year-old patients who have smartphones, and they, have about 1 or 2 apps on it. If you can add that while they're there and briefly show them how to use it, it pretty much teaches, it will teach, they can teach themselves how to use it. Going to shift into the documentation stuff. We're almost done here. I'm going to go through this.
I've got about 3 or 4 minutes left. We're starting to lose some folks, and I've got a couple of questions. But go ahead and wrap this section, please.
Okay. There's just really one point I wanted to make here, that a lot of people don't realize it, but using the new charts in 2007, the definition of legal blindness went to, if they cannot see the 2100 line, you are now legally blind. It's not 2200. So on the ETDRS chart, if you cannot read any letters on the 2100 line, you are legally blind. So be aware of that. And like I said, if you have a question while I'm paging through these, I want to get to the last section. It's going to show you how to calculate visual efficiency, but that's for another time. That doesn't come up very often, but it's nice to know how it works. You can go on the Social Security website and read about the definitions of that. AMA has their guides to permanent impairment. That only really comes into a case where you're trying to show visual function, loss of function, sometimes in legal cases where you might have to do that. And of course, there was another question here. So if you want to do that one real quick.
No, we'll go ahead and skip.
Okay.
that.
And my favorite slide in the whole presentation, that usually means I've got 10 minutes left, but we'll have to kick it in gear. The last section is quickly evaluation and billing changes. Again, since we're in private practice, the WHO has their model of how we look at things, pathology, impairment, disability, handicap. The pathology is the macular degeneration. The impairment is, well, I can only see 2200. The disability of seeing 2200 is I can't read standard print, and that leads to a handicap at school and at work. And then this just kind of shows where all of the professionals are involved. How do you bill a low vision exam? Well, using the medical model, the optometrist or ophthalmologist is a physician, and then we get the rehab services that occupational therapists do. The role of the physician is to confirm the disease, determine how much impairment that's caused, and determine the disability, and then is there any kind of rehabilitation that we can do to help them. The diagnosis then becomes that you would bill would be this ICD-10 based on their acuity, the H54 series, which there's several of them. Low vision category 1 is 20/70 to 2200, so forth. Blindness starts at 2400 or worse. And remember, the blindness categories can include visual field loss below 10 degrees. So when you look these up in the ICD-10 book, there'll be H54, it'll say low vision, category 1, right eye, blindness, category 3, left eye. So you just find the combination. Billing these, I used to do a whole course on billing, but it's really gotten pretty easy. We had been using, we still use E&M codes for all low vision. We're no longer using the 1997 guidelines. We're now in the 2021 guidelines, which has made it easier. You have key components, but you don't have to have every single one. Time has really become the major component. So most of our patients, you're going to be able to bill a moderate complexity E&M if they have 1 or more chronic illnesses, 2 or more stable illnesses, such and such, or even a level 5 that way. But time becomes the component, and you can look these up in your book, but 60 minutes, you're going to get a 99204. They've eliminated 99201. If you take more than the stated time, you can use something called a prolonged service modifier. And remember, your established times are going to be shorter because you've seen the patient before. This is a new code for this year. If you want to do prolonged services, you can bill the level 4 E&M, and then you can bill this 99417 that replaces that G22, but you bill those in 15-minute increments. So if you go over the maximum time for the E&M level that you actually performed, then you can add extra time. So that's a way to, if you have somebody that takes a little bit longer, you can at least get reimbursed for it. So bill your E&M service, add the prolonged modifier if appropriate, bill a refraction. Remember, you spend a lot of time determining refractive error, best eye, right, left. Bill a visual field. If you're doing an Amsler, consider a low level field or a kinetic. You can do a threshold if it's indicated, and bill a photo or an OCT retina. So anyway, sorry that took so long. I get really excited about the eccentric fixation, and I think it's something we all understand. I hope you understand it a little bit better, but it can make such a difference in our patients' ability to deal with their vision impairment that please keep that in mind. Try to find the eye that works better. Those are some ways to find out, and then help them to use the eye that works better, and then add the low vision aids if necessary. There's my email. Please feel free to reach out. It's exciting for me to have students contact me that it's exciting to do low vision, and we need more of us in private practice doing it. So thank you for your attention tonight, and I'll stay on as long as we need to.
Thank you so much, Dr. Krug, and thank you to the Macular Degeneration Association for helping us put this together. There are a few questions that are posted. What we'll do is maybe stay on and type some answers out to those folks that we didn't get a chance to answer their questions live. And again, an email address has been posted here on the screen if you have some specific questions and want to reach out directly. Thank you very much once again for joining us. We'll send out C certificates to everybody via email, as well as I mentioned earlier, post the hours electronically to the COPE site on your behalf, to the Texas boards on your behalf, and to Florida CE Broker for those licensed in Florida. This concludes our program. If you want to stay on and get an answer to your question that may have been posed, we'll type some of those answers in for you. Thank you.
Good night.
Dr. Krug, do you mind if you click on the top of your screen, you'll see Q&A, and it'll take you to the box that will open up those, and you can just type answer. If you click on the type answer box, you can respond to some of these questions that have not been addressed yet.
Okay. So just type them on screen,
Well,
or type them in the box, or actually verbally respond.
If no, you can type them in because I think a lot of people are dropping off. We had great success tonight, over 950 attendees, and so a lot of them are filtering out right now as we're speaking. But if you don't mind, if you click in the Q&A section, do you see that?
Yeah, I've got it open.
Yeah, just type answer. If you click type answer, you can respond directly to those folks.
Okay.
Thanks again, Kendall.
Yeah, Jeff, good to see you. I hope you're healthy, and I hope to get to Kansas City one of these days.
Yeah, I hope to get anywhere one of these days, right?
Yeah, my big event tomorrow is I got my second COVID shot coming at 7 a.m. So I hope I'm still standing the rest of my days.
Yeah, I've actually got mine on Thursday, so I'll be right there with you.
Yeah, I had a sore arm, and it was red for about a week, and it really messed with my blood sugars, and that took about 10 days to go away. But I don't know if you know any other type 1 diabetics, but it was weird. It was like I was doubling my insulin pump dose, and it was still running at 300. It was very frustrating. So
Oh, wow.
it
Wow.
had to have had something to do with it. I know the vaccine has an adjuvant in it, so it probably riles up your immune system.
Wow.
So
That's crazy. The one other person I know that does have type 1, he did not have any such reaction, but it's so variable.
yeah, it'll be interesting to see what this next one does to me. So
Yeah, I've read everything from nothing to totally down and out for 48 hours. So
wow. Yeah, it's amazing how many of those people we're having to explain to explain their COVID symptoms and the whole vaccination thing.
yeah.
It's frustrating.
Yeah.
We've got a live program in Mexico at the end of February, and we've secured testing for everybody to get back into the States based on the new CDC requirement. And we're working right now on trying to secure solid information from the CDC on guidelines for those that have already been vaccinated. It's our understanding they're going to come out with a new provision where if you've got the vaccination, you just have to prove it with your medical card and perhaps a letter from a physician or the clinic where you got the vaccination and certifying such, and then you'll be cleared to re-enter the States.
Oh,
A lot of our attendees at our international programs are getting vaccinated, just like you guys are right now. Jill just got her first dose a couple of weeks ago and gets her second dose here, I think, later this week. And so vaccinations are going to be very important for our travels with our groups.
Yeah, makes sense. Makes sense.
Getting a lot of questions about the Seeing AI app that you mentioned. It looks like a lot of people are saying it's only available for iPhone and iPad, not for Android. If anybody,
No, it was available for Android. I'd go to the website or search for it.
okay.
All right, guys, I'm logging off. Thanks again to both of you.
Thanks, Jeff. Take care.
All
Thank
right,
you
take care, guys.
so much, Jeff. All right, I addressed some of those questions that were about the survey and evaluations and
Okay.
so
I'm down to my last one here.
we've got them wrapped up. I'm gonna, when you get that last one posed, answered, I'm going to close down the presentation and log the recording. Thank you so much for your time.
You bet. I appreciate the opportunity.